Hi everyone, Dr. Jay Mehta here. This is a masterclass on lymphocyte immunization therapy. Just to give you a core concept, PLIT basically reprograms the maternal immune system to tolerate paternal antigens. When exactly do we have to do it? Just remember some things, guys. Please consider this as a therapy which gives you a 10% or a lesser benefit for a patient who has had 3 or more consecutive losses. This is basically done to form blocking antibodies. That's it. Blocking antibodies are protective against NK cell activity, and sometimes it is believed that the mother doesn't produce them enough. Due to this, there is recurrent abortion as far as the couple is concerned. Now, this is something which we want to change. To understand this, understanding TH1, TH2 balance is important. Remember, it is like a swing. If TH1 is more dominant, then trophoblast has an attack and chances of miscarriage are high because NK cell activity increases. TH2 or helper cells are basically protective and they help the formation of blocking antibody, creating immune tolerance. This is it. To achieve this, you basically need antigen sensitization through the paternal lymphocytes. Then there is polarization. Then there is blocking antibody production, and only then there can be tolerance. This is a simple mechanism. It doesn't really change. It has been studied extensively. So what do? Paternal lymphocytes are injected intradermally. Mother or everybody has dendritic cells. This dendritic cells catches hold of that and goes and takes it to CD4, which produces helper cells too. TH2 then activates beta cells in the body. And once activated, it produces blocking antibodies. As a patient or as a clinician, just remember this, nothing else. This blocking antibodies protects the trophoblast of the mother against the NK cells. That's it. How do we do a pre-procedure workup? Of course, husband-wife. Both the routine serology for husband, for wife has to be done completely. Certain additional tests, especially the viral markers, need to be performed. CBC and karyotyping, because all LIT will work only for a chromosomally normal embryo. That means you need to rule out all causes for having recurrent abortions in the couple. Once that is done, once an embryo is formed which is genetically normal, only then please go ahead and do LIT. Not like how it is done in India where every patient gets an LIT. Okay, please don't do such type of things. It is illogical. How do you actually do this entire procedure? We call the husband approximately with 4 hours of fasting. A venipuncture is done. Separation is done using Ficon media. Isolation is done. It is studied under a slide. And then an intradermal injection is done approximately 1 centimeters apart, preferably on the forearm. 2 forearms, 2 on the upper arms, everything is fine. You need around 6 to 8 sites of injection, right? This basically, if at all a booster is required, then we do a booster after 2 to 3 months. But we do not like to do this once the patient is pregnant. What does the evidence say as far as the outcomes are concerned, right? The live birth rates following this entire procedure, okay, goes up in well selected and in indicated cases. That is one study. But the data overall is inconclusive. That means your selection is the key. If you do PLIT for everybody, you will spoil the name of the procedure. That's why do a good case selection and implement it nicely.